Yep, let's see. We'll put it back in. All right. How's that? Looks okay still?
Yeah, that's perfect.
All right. Welcome, everybody. I met some folks. I think number one, just through the meetings that we've been having, I see some familiar faces. And then some, I think, at the tailgate too. So it's good to meet some folks. My name is Steve Adolfsen. I've been here as an attending since 2009. So I guess 11 or 12 years now. So I was actually a Rutgers undergrad, and I did the 7-year program at Rutgers and Robert back when it was UMD&J for med school. And then I went up to Yale for my residency for ortho in New Haven and spent 5 years there. And then I went down to Dallas, Texas for a 1-year fellowship at Texas Scottish Rite in Dallas. So then I've been back here now for 12 years. So for a topic, we can definitely keep it. Some of you may have heard me and Steve talking, but we can keep it pretty light. So if people have questions, you can certainly chime in. But there's going to be 5 topics, so I'll pause after each one, and then we can kind of talk about each one. So I always thought it was a funny slide. So people always ask why kids get hurt on monkey bars. So monkey bars is probably like the top offender of what we see in the office for injury, especially for extremity injuries. So you can imagine being 3 feet tall and 6 foot monkey bars is twice their height, right? So these would probably be like equivalent monkey bars for an adult. So you can imagine climbing up there doing 12 foot monkey bars. So in general, before we get to the 5 topics, and these are good things just to keep in mind for any, especially injury, right? It's just time and mechanism of how it happened, site of injury, the neurovascular status, and then appropriate radiographs, right? So almost all radiographs have at least 2 views, right? A lot of them have more than 2 views. Temporary immobilization, and then timeliness of referral. So the whole point of this talk is pediatric orthopedic emergencies, right? But you can kind of break it down into like 3 different levels, right? So there's the emergencies. So the 5 we'll kind of focus on today is a septic joint or an infected joint. Number 2 is an unstable skiffy. So if you haven't heard what a skiffy is, we'll talk about it. Compartment syndrome, open fractures, and then some elbow injuries because they have a tendency to swell more than others. So those can be emergencies. But you can also have a level of injuries that we kind of label urgent, referrals. So these are frequently ones that still show up to the ER. Occasionally they will show up to the office, but they usually end up showing up in the emergency room. And examples of these could be displaced or angulated fractures, even some non-displaced fractures, dislocations, finger and nail bed injuries, crush injuries, things like that. So it's not to say that they're not important. It's just what we're talking about today is kind of like the true pediatric orthopedic emergency, something that need immediate attention and frequently in the operating room. And then you kind of have the 3rd level, which is kind of your elective or subacute, kind of referrals. And these are ones that they can show up to urgent cares, emergency rooms, the office, and they can be kind of temporarily splinted and then kind of follow up in the office. So a lot of these kind of don't end up showing up in the emergency room. They come straight to the office, or they go to an urgent care or their pediatrician, and then come to the office. In general, a little bit of a difference between pediatric and adult. And if some of you maybe have seen some ortho, maybe not. But in the younger kids, the ligaments are actually stronger than a lot of the bones. So the metaphysis of the bone and the physis, the growth plate, are actually a little weaker than the ligaments. So it's actually a little less common to get sprains in kids. It's actually more common to get little buccal fractures, or what we call occult fractures. So fractures that don't necessarily show up on the first X-ray. So even if you have a negative X-ray, if you have point tenderness directly over a bone or metaphysis and end of a bone, it's a fracture really until kind of proven otherwise. And when in doubt, splint. And if you're in a good splint, they should be seen certainly within a week. I mean, we actually try to aim to see them within 3 or 4 days in the office. And then you guys, I'm sure, have heard the rice rest ice compression elevation is kind of what we teach the pediatrician. So again, so we'll go back to, number one, septic joint. So again, true pediatric orthopedic emergencies, and these are pretty common. So Robert Wood, we probably see at least 4 or 5 septic joints a month that come into the ER. What I want to do is I wanted to highlight septic joints with a case. This is actually a case from down in Texas when I was down there doing my fellowship. So it was a 9-month-old boy who kind of presented outside, and Texas is a big state, so they don't necessarily always go to an ER. There aren't always, ERs in every town. So by the time he actually made it to Dallas, it was quite a time later. So he had a low-grade fever, wasn't moving an extremity, a recent history of a upper respiratory infection. They kind of just got X-rays and presumed it was an infection, and kind of started treating them with antibiotics. When they weren't improving is when they looked to send them up to a higher level of care. So after a week later, they show up finally to Dallas, and they start with just repeat X-rays, and already there's kind of a bad sign of this X-ray on the right. You could see, so the right side's over here. You guys can see my cursor, right?
Yes, we can.
All right. So on the right side here, you can see that the hip's not perfect, so it's not perfectly centered, right, in the hip, like in the acetabulum, like it is on the other side. So that's kind of a little red flag that there's probably something going on. So this kid needs kind of a better imaging. So they got an MRI, right? Same idea. This is kind of a coronal slice, so it's almost like you're looking at an AP pelvis, right? X-ray, and you can see there's definitely something, right? I don't think you just look at symmetry. You can see that there's definitely something going on the femoral head, right here, kind of down into the femoral neck. And then there's definitely something going in the joint here. So that's actually what's displacing the hip. So the hip looks like it's starting to sublux because of a raging infection. So it probably wasn't an osteomyelitis, it was a septic joint that now has been brewing for seven or 8 days. So this kid needed a lot of help because it had already gotten to that point where now it involved bone. So technically you're going to call it osteomyelitis. And then septic arthritis because it's an infection in the joint, and now you have a problem with the hip being sublux, so you have to try to keep that reduced. So the kid did go for surgery. Actually had a couple different surgeries just for irrigation and debridement to wash out the joint, and then to make a little window in the top of the femur here, and then try to get rid of some of the infection there, and went back every 48 to 72 hours for washouts. But what I wanted to show you is I want to show you what happens when it doesn't get treated right away. So this kid actually had some follow-up and some longer-term follow-up. So after being treated appropriately after 7 or 8 days of being missed, already at 6 months, right, you can see that there's a difference in their X-ray, right? So this is called the ossific nucleus, right? It's the center of the hip. It usually ossifies first, and then it gradually moves out, becomes bigger and bigger from the center out. So it's always a bad sign when you see that the ossific nucleus is absent, right, in that hip. That's kind of a sign that there was some death or avascular necrosis of the hip joint secondary to the infection. And then if you follow for a little further out, a year later now, still hasn't really shown back up. And now 3.5 years old, so that's almost what, 2.5, 3 years later. You can see that it's trying to kind of reossify or remodel, but it's certainly not normal. And then at 6 years old, so another 2.5 years later, you can see that there's a little fragment of the head here. There's a fragment here. So the joint, you can imagine what it looks like. It probably has a huge divot and some loss of cartilage because bacteria loves to eat cartilage. And then at 8 years old, you can see this is what we call a scanogram. So this is kind of an entire lower extremity X-ray. And you can see what we were talking about before. Now that more of the femoral head is kind of ossified, you can see there's kind of this big divot in the femoral head, and it doesn't really match the roundness, right, to the acetabulum. So this is basically a hip that's doomed. So it already has what we call arthrosis, which just means loss of cartilage and inflammation. And it's doomed for arthritis probably in the next few years. So you can imagine being 10 or 11 years old and already having end stage arthritis. So big problem. We don't usually we do some total joints in kids as young as their teenage years when we have to, when our arm is forced. But remember, those have a limited longevity in the future and are, prone to need revision. So you want to certainly try not to. And some of these kids actually go on to need a fusion. So we actually fuse their hip up here. They make up for it through their lower back, their knee, and their ankle. But then usually develop problems later on and need a total hip, a conversion to a total hip when they get a little bit older. And then you can see secondary problems here. The kid also has a leg length discrepancy, right, of up to almost 2 inches. So that's going to be an issue as well. So they'll probably need surgery for the other side just to slow down the growth of the other femur, just to try to have equal leg lengths at the end of growth. So just that 7 or 8 days, this is why that fits into that emergency category. So we take these pretty seriously. Anytime there's a suspected septic joint, we try to get it to the OR. In general, just to give you some background of septic arthritis, the classic age for it is the younger kids, the 1 month to 5 year olds, and by far the most common, 2 out of 3 are either hip or knee. So by far, we're seeing a lot more hips and knees. It's your common pathogens, right? You're going to hear Staph aureus all over the place. So the vast majority are Staph aureus. It's just a matter of whether they're MSSA, so sensitive, or MRSA. And it's important to keep in mind that it's funny because parents always ask the same questions. They say, how did this happen? Or how did it get into the hip joint or the knee joint? It's almost always hematogenous, right? So hematogenous just means from the blood, right? So these kids get bacteremic from who knows where, from a cut, from their mucous membranes, from their mouth, from somewhere. And then once the bacteria gets into the blood, then it can circulate, right? And it can go anywhere throughout the body. So it happens for 2 different reasons for a septic joint. One is that it can actually seed the bone first, and then it can go from the bone, right, into the joint. And then the second is it can go directly to the joint because the capsule, right, of the hip and knee joint are very vascular. So those are 2 easy ways for the infection to find its way for the joint. And always remember that. So it goes from blood to joint or bone, not the other way around. Even the pediatricians, when they're in their residency and fellowship, seem to have a tendency to forget that. They think it was a septic joint, and then they say, oh, look, and they also have positive blood culture, so it must have gotten into the blood too from their joint. So we have to treat their bacteremia, but it's the other way around. This is just kind of a pictorial, right, of 4 different joints. These are the 4 joints, right, of the body where the metaphysis, right, so the top of the long bone is actually intracapsular. So these joints are a little bit more likely to develop kind of a direct spread into a joint. So A and B are the upper extremity, and C and D are the lower extremity. So A is the elbow, right? So the very proximal radius is intracapsular in the metaphysis, and then the proximal humerus is intracapsular in the metaphysis, and then the hip and the ankle, both the proximal femur, as you saw in the case that we showed, and then the distal tibia and distal fibula are both intracapsular. So a little bit more likely as well for these to seed directly into a joint. So what do we do to work these kids up? So you guys may have heard us kind of say that they're toxic appearing, or if we say that they look like they're toxic, just an overall sense that they appear ill. Kids, especially up to age 5, just have unlimited energy and they want to bounce off walls and jump around and play. So when you walk into a room and they're holding their leg in a certain position, refuse to weight bear or get up, and just look ill, that's what we mean when we say that they kind of are toxic appearing. And then our blood work, the classic, right, is a CBC to get a white count, an ESR, a CRP, blood cultures, and of course Lyme. So that's because of where we live, right? It's actually pretty common in the Northeast to have Lyme, and Lyme is a great mimicker. So it can actually look like even a raging infection. So I've seen some kids look toxic, who are very sick, have a high fever, and it ended up being Lyme. Hip and knee ultrasound can be helpful, especially the hip ultrasound, to see if there's fluid in there, which I'll show you kind of a picture of what a hip ultrasound looks like. On our differential is transient synovitis, which we'll talk about in a second. Reactive arthritis or juvenile idiopathic arthritis, which is like a juvenile rheumatoid arthritis, can present just with a single joint effusion and a low-grade fever. Lyme, like I just mentioned, which is pretty common in our northeast area and can certainly mimic an infection. And then different types of infection, right? So infection at or around the joint can kind of look like a septic joint too. Transient synovitis we bring up a lot because that is actually can also mimic what a septic joint looks like, but the treatment is completely different. It's the exact opposite of the treatment for a septic joint. So septic joint is antibiotics and surgery, whereas transient synovitis is usually self-limiting and it runs its course over 10 to 14 days. So our big kind of issue in the ER is trying to figure out if this 3-year-old, it just has a transient synovitis, which is usually a post-viral syndrome. So kids have like a recent upper respiratory infection, runny nose, and then a few days later, they start to develop an inflammation of the synovium, and it can be the same joints, the hip and the knee are the most common. And that's frequently what we're trying to kind of differentiate because it's a difference of whether you're taking the kid to surgery within 6 to 8 hours, or if you're telling them that it's a self-limiting process and not to worry about it, and that they're going to be fine. So how do we do that, right? So we do that with research. So this is actually Min Coker's up in Boston at Boston Children's at Harvard, and this is probably in the late 80s. He came out with a criteria we call the Coker criteria, and the top 4 at that time were fever, history of non-weight bearing, true non-weight bearing. So not just that they're kind of hobbling around, but they truly, like a 3 or 4-year-old who refuses to bear weight. So they won't get up, they won't walk, they won't jump or play or do anything. ESR over 40 and a white blood cell count greater than 12. This was back before CRP was big. So he actually did a follow-up study with CRP because CRP is probably more helpful. ESR goes up quickly, but it takes a long time to come back down, whereas CRP seems to be much better barometer of the inflammatory cycle. So we've actually switched that out, but his original criteria were ESR. And the reason it was important is because he did a logistic regression, and he went back and he looked at all the kids who ended up having a true septic joint. So after having an irrigation debridement and having a positive culture for bacteria, he went back and he looked to see of these criteria which those kids had. So you can see a huge jump. So when kids had 3 or 4 of these above Coker criteria, the chances of them having a true septic joint jumped, right, from 40% to 93 and 99.6%. So this is what the residents use in the ER. So when kids come in with a rule out septic joint, they're looking at these kind of Coker criteria: fever, non-weight bearing, CRP, and white blood cell count. And if they have more than 2, we have a pretty high suspicion. So those are all the kids that are getting further studies. So those are going to be kids who get ultrasounds, and then eventually, most cases end up getting an MRI just to look for it. Ultrasound's a lot easier to get because you don't need sedation, right? So you can imagine a little 6-month-old or a 1-year-old and trying to get an MRI. It's an endeavor, right? So it's basically a procedure. So they have to be fully sedated. So it's general anesthetic when they go down to the MRI suite. So that can take several hours to get it. Whereas the ultrasound you can usually get within 30 to 60 minutes. It's really helpful in the hip. The knee, we're not as worried because we can aspirate the knee to get some fluid out of it. The hip is much more difficult to try to aspirate because you need a fluoroscopy suite or you need interventional radiology to try to get a needle into the hip joint. So an ultrasound can help just confirm that there's fluid in the hip joint. So this is kind of just an example of top of what it would look like with an effusion, and then on the bottom without an effusion. I know, when I first started, ultrasounds always kind of looked like a Cincinnati snowstorm, but you really can, you can really see a difference, with the pictorial on the right of, the top of the femur, some metaphysis and epiphysis, and then the capsule distended here because of this right here, this oval, right, of fluid sitting against the anterior femoral neck. Whereas down here, there's no kind of black oval of fluid. The capsule's kind of resting right on the anterior femoral neck. So we get labs first, and then we get an ultrasound of the hip. And if the ultrasound shows an effusion, then those are kids that have to get an aspiration to see what the fluid in the hip is, and if it's infected. And the way they do that, so with the aspiration and getting the fluid out, is we look at the cell count. So you can do just similar to, I'm sure with maybe you guys have heard of doing cell counts for other body fluids like CSF and meningitis and the breakdown. So this is kind of the orthopedic equivalent. So joint fluid analysis. We're looking primarily at cell count, and it's because the cell count we can usually get within 30 minutes. So they can send it to the lab and they can do a cell count once they receive it, usually within 30 minutes. So we can get an ultrasound within 30, 60 minutes, and then get a cell count once we get the fluid out within 30 minutes. And 50,000 white cells is kind of the lower end of what I've kind of seen and heard. Most people use 75,000. If it's over 75,000, it's definitely worrisome for a bacterial infection and not just an inflammation. But it can help you kind of rule out some of these other, say, rheumatoid causes. So like JRA or JIA typically has kind of like a 15 to 50 or 15 to 40,000 range. So that could save somebody from kind of an unneeded surgery. Lyme is all over the board. I've seen Lyme come in at 10,000. I've seen Lyme come in at 200. My highest was at St. Peter's, and a little 1-year-old who had a cell count of 220 something thousand white cells. We said it's definitely an infection, and it ended up coming back Lyme. So it can definitely be the great masquerader. So I'm going to stop talking for septic arthritis because I want to hear kind of if there's any questions or anything for septic arthritis. So septic arthritis is one that we take to the OR usually within 6 to 8 hours for an arthrotomy. So a true kind of open, arthrotomy just to relieve pressure and then wash out the joint. And then we have a very low threshold to go back to the OR if we need to, say 48 hours later to wash out a second time. And then, of course, antibiotics, right? Because these kids, by definition, are bacteremic. So they have bacteria in their blood. So they need, usually, the average is about 6 weeks of IV antibiotics. So they need a PICC line inserted too. And then they can go home usually with a PICC line. So septic arthritis is one of those things that usually needs both, right? So you need primary treatment of the infection, which is the antibiotics, and then treatment of any pus in a closed space is going to be surgery. So it's kind of a combo. So always keep this kid in mind. So I tell the residents, I show them this picture, right? This is what can happen if we misdiagnose it in the ER. So is anybody alive out there? You still can hear me? I'm not breaking up all over the place.
Hey, Dr. Adolfsen.
What's going on?
I just had a question about so when these kids come in and you get them into the operating room within that 6 to 8 hour window, what is the success rate of these kids going on to normal development? If the parents start to ask you that after you come out of the OR, because I'm sure they have a lot of questions.
Yeah, very good. So usually the outcomes are pretty good. So as long as it really depends. It's funny, right? Because we kind of use the 6 to 8 hour rule, right? I'm sure you guys have seen this maybe with open fractures or other things. There's this kind of magical, orthopedic 6 to 8 hours for emergencies. But that's like from when they walk through the door, right? So who's to say that one parent isn't really attuned to their kid and doesn't bring their kid in like within a day of them complaining of pain, and then there's another parent who watches it at home for 3 days, and then it's kind of slowly bruised to the point where they're finally worried enough about it that they call their pediatrician. Their pediatrician says go to the ER to rule out a septic joint. So those kids are 3 days off, right? We took them to the OR within 6 to 8 hours for each one. So there's definitely a little bit of a gray zone in there. I think the bottom line is just that it's an emergency. As soon as it's identified, no matter how long it's kind of been going on, it should go to the OR. And in general, usually by the time the kids actually get sick, like when they actually truly are bacteremic, they look toxic. Their parents are worried. So they seek care, and they come to either the pediatrician or the ER. So they're usually to us within like 2 days. And then as long as it's identified within that few hours that they kind of show up to the ER, and then we take them to the OR, within 6 to 8 hours, the outcomes are actually very good. So most kids kind of have no long-term sequelae, like I would say over 90%. But it just, the key is identifying. You can usually tell too when you bring them to the OR and you wash it out what the cartilage looks like. So you can see kind of how far, behind the 8 ball you are too. A lot of us will use that too to decide if we go back to the OR. So if it's somebody who's caught like really early, then and it does, the cartilage looks completely pristine. A lot of those kids just need one surgery. Whereas kids who show up late, you get probably get 30 cc's of pus out of their knee or out of their hip, and the cartilage already looks like it's kind of like a yellow, kind of a manila or yellow, not bright white. Those are kids that a lot of times we'll take back for a second look, in 48 hours. But you always want to err on the safe side, right? I'd rather bring a kid back to the OR 3 or 4 times and then not develop end stage arthritis that needs a total hip at 18 years old. Take them back a few extra times. And most of us will consider Lyme kind of a necessary evil. So just like with our general surgery colleagues with their appendectomies, I don't remember what the number is they quote, but there's a certain number of appendectomies they do that end up coming back negative for inflammation. And it's just kind of an accepted norm, that you're going to get, 1 in 50 or 1 in 40 that probably were appendices that didn't need to come out. We kind of consider this like the orthopedic equivalent. It's fine to find out, a day or 2 later that their Lyme came back positive and you already washed it out. Because Lyme will usually go away just with antibiotics. They don't need surgery for a Lyme arthritis. But we'll take that risk and take them to the OR just to be safe and wash it out, and then find out later that it's Lyme.
Dr. Adolfsen?
Yeah.
Maybe I missed that, but the case we were talking about, would you consider doing a arthroplasty in that hip? And what would that look like, sort of?
Yeah, so we definitely, I guess the youngest we've done it here is 16, a total hip. And that was on somebody who had avascular necrosis. I don't know if it was for an infection. It was Dr. McPartland's patient. And yes, it's something you can consider. The problem is its longevity. So, yes, it's great as long as they don't get an infection right from the total hip, right? So you have to make sure that that their infection is clear. And a lot of total joint surgeons will actually go and do a biopsy and a culture twice. So actually open up the hip joint, send synovium, send cultures, and then wait, and then bring it back a second time and send biopsy, send cultures, make sure there's no signs of inflammation of the synovium, and that there's no positive cultures, and then they'll go back into the total joint. As long as everything goes great, kids are young and healthy, yeah, they'll do great for a while, right? But the longevity of a total hip depends who you ask. If you ask the total joint surgeons, they'll say it's forever, but it's not forever, right? So eventually mechanical things are going to wear down. So, an 18-year-old with a total hip, probably 20, 25 years is a good probably average, right? But then you're talking about a 40 to 45-year-old now who needs a revision. And then usually, rule of thumb is you can cut that in half, right? So if the first one lasts 20 to 25 years, the second one lasts 10 to 15 years. The third one lasts 5 to 10 years. And then they're in their 60s and they may have 3 or 4 revisions of a total hip. And if they get a complication, right, like a dislocation or an infection later on, or it's a nightmare to have a 30-year-old with a complication from a total joint. So a lot of those kids, we're really talking about a fusion. It's actually fusing their hip joint. So taking away all the cartilage and getting the top of the femur to fuse to the pelvis, and they make up for it in other joints. And then bring them back later on. When they're in their 40s, so you can get them to their 40s, and then you can actually take down that fusion and do a total joint. Not easy, but doable.
Hey, Dr. Adolfsen, I just had a quick question in regards to these patients who have recurrent infection and you have to take them in for multiple washouts. I know when you're dealing with a total hip, you can usually do a 2-stage procedure involving an antibiotic spacer or prophylactic beads. Do you ever have to do any 2-stage procedures for these young kids that you don't want to incorporate a total joint?
Yeah, absolutely. It's a good question. So not usually for the joints. So in other words, for the septic joints, it's really just a matter of washing it out. And it's the number of times that you have to wash it out. And then just letting natural history take its course and see what cartilage survived and which cartilage didn't survive. But where we end up using antibiotic beads and kind of antibiotic cement or calcium 5-phosphate a lot is in osteomyelitis. So infected bone. So kids who show up, who have an infection of their tibia or femur. It's not a joint, it's not a septic joint, but it's an infected bone. A lot of those kids create dead space because of their infection. So the infection went so long that it actually ate the bone. So now the bone, you go in and debride away a bunch of bone and you're left with this dead space. And we'll use a lot of kind of antibiotic spacers and beads and things for that, but not as much for joints. Yeah, the adult guys use those kind of antibiotic spacers a lot for infected total joints. In other words, somebody who had a total joint and the total joint got infected, so the metal actually got infected. So now they have to take it out because the metal has a biofilm on it that you can debride it all you want, but it just keeps coming back, over and over. So they have to take the metal out, and it's hard to leave nothing there, right? So if you can't just take the metal out, so they take the metal out and they put in like an antibiotic preformed spacer. Yep, in the joint. But in peds, we try to wash it out, and then when the infection's eradicated, wait it out and see what the kind of healing potential, for the joint is.
Great, thank you.
Yeah. All right, should I push ahead?
We actually have one more question that came in the
yeah.
chat. They're wondering what extra measures you have to take when operating on patients who are immunocompromised or have autoimmune disorders.
Yeah, so we definitely work with our colleagues, our hematology colleagues, because we will see some kids who have underlying conditions who develop an infection. In general, our job as orthopedists is pretty similar in terms of we're kind of taking care of the pus in a closed space. So for us, it's just a matter of going back and however many times you need to. So they may end up needing more washouts, but you just keep going back until the pus in the closed space is gone. And then our infectious disease, our pediatric ID colleagues help us out in terms of choosing antibiotics. A lot of times they'll go with a broader spectrum of antibiotics, and they'll go with a longer period of antibiotics after the surgeries. But for us on the orthopedic side, really kind of what it changes is just maybe how many times you have to take them back, to the OR until the joint's actually back to clean. All right, I guess I'll try to get through more than just one. I'm gonna keep it. I'll keep it on time. We'll end at 6. We'll do 5 to 6. So let's try to go through a couple more. I'm gonna leave like at least 5 or 10 minutes at the end too, just for general questions about ortho, or doesn't just have to be about peds ortho. So infection was a big one. Skippies are a big one. So I don't know. I wouldn't expect you to hear. I didn't probably know what a skippy was when I was a first year med student. I probably heard about it when I was maybe a second or third year med student. So slipped capital femoral epiphysis. So another one kind of at the hip. This is an example of somebody who has bilateral slipped capital femoral epiphysis. So capital femoral epiphysis is just basically an old school name for the epiphysis of the femur. So when we say slipped capital femoral epiphysis, it basically just means, right, that the epiphysis is sliding off, right, the top of the femur. So these are kids that this is kind of the typical patient that we see. Now, not everybody reads the textbook, right, or follows the rules. So even though this is what's all over the, kind of the tests and test questions and things like this, the typical kind of skiffy patient is adolescent. The classic age, average age, they always say is about 12, but you can see it as young as 7 and as old as 16. So there's definitely ranges, but the classic, average they will test our residents on is 12. Obese or overweight, limping. So they just kind of show up. Sometimes they don't even say it hurts. They just have this painless limp where they turn their foot out and then they kind of limp along, and then gradually hip and knee pain can kind of sneak into the picture. But early on, it's really just this painless limp and walking with their foot kind of turned out. So the definition, really, we kind of describe it to patients as saying that the ice cream is kind of falling off the cone. So you can see like the top, the head, the nice round femoral head is kind of sliding off, right, of the top of the femur. But you know us, that's an easy way to explain it, to patients. It's not, it's actually the opposite that's happening. So the head is actually staying in the cup, and then the proximal femur, the metaphysis, is actually displacing anteriorly. So it's kind of it's the opposite. So even though it's more fun to say that the ice cream's falling off the cone, technically it's not what's happening to metaphysis. You look like a rock star if you're in conference and you mention that it's not really the head falling off, it's the metaphysis displacing. So I'd be impressed if you remember that. And it occurs that adolescent years, because that's when they're a rapid, right, growth. So they're undergoing rapid growth, and this is one of the growth centers, right, of the lower extremity. So typically in boys, a little bit later, I would say 12 to 16 are kind of their height of their adolescent growth spurt, and girls a little younger, right? So age 11 to 14. And the slip is through that layer of hypertrophied cartilage cells. So that's just kind of a cross section, right, of an actual slip. And it's a weakness, an inherent weakness of the growth plate through the hypertrophied cartilage cells. So when you think about etiology, it kind of makes sense, right? Because the most common etiology is mechanical. So that's why we say kind of an overweight or obese adolescent, because of the just mechanical etiology of shear, right, on the top of the femur pushing down. So the physis isn't horizontal, right? It actually has a little angle to it. If you imagine somebody standing, right, for a standing AP pelvis, right, the physis isn't perfectly horizontal, so it's subject to shear. So you can imagine an obese adolescent, right, and how much weight they put on the top of the physis, on the top of their femurs. So it's kind of a slow, gradual process. That's mechanical etiology. There's other etiologies, right, and endocrine. So we can see skippies in kids who have other endocrine abnormalities. So we think it's those kids, it's probably more related to the underlying mechanism of action of their underlying problems. So hypothyroid is kind of a common one. Kids with Downs, kids also with renal disease, so end-stage renal disease, and it's probably because of their mechanism of action on the growth plate. So there's probably some mechanism of action that's happening at the physis that's causing the weakness. And the reason we bring this up is because these are probably the kids who are not the typical skippies. So these are like the younger kids who are probably less than 12 years old and say like skinny. So you have like the skinny little 8-year-old who walks in with a skippy. It's probably not your typical skippy. It's probably an atypical skippy. And sometimes it's the first time they show up and don't even know they have an underlying endocrine problem. So these are kids who don't fit the typical picture for a skippy. We may be the first ones to notice it and actually send them to their pediatrician or tell them that they need a pediatric endocrine workup. And then they come to find out that they're hypothyroid or have a growth hormone deficiency. And that's actually what caused their slip, and it was their first presentation. So this is an interesting picture because this is actually an old school picture of a knee arthroscopy, right? So why am I showing an old school picture of a knee arthroscopy? It's because a lot of these kids show up with referred pain. So they have pain that they say is in their distal thigh or their knee. So there's a handful of case reports and studies out there where kids actually showed up, 14-year-old, 13-year-old showed up with this unexplained knee pain and went to see an orthopedist. Maybe they didn't see a pediatric orthopedist. Maybe we'll make fun of the sports surgeons for a second because there's none on here. As maybe they saw a sports orthopedist and they said, well, their knee hurts. There's got to be something. They get an MRI. Maybe they see something, a plica or something. They say, well, let's just scope it and see. Maybe it's their medial plica that's causing pain. So they have a knee arthroscopy and everything comes up negative. And finally, they start developing more kind of thigh pain, and then it's really kind of more hip pain. And they finally figure out 3 to 6 months later that it was actually a skippy. So yes, there are patients out there who kind of get misdiagnosed. All these skippy patients have a funny story. They all have been somewhere. They've been to other doctors, physical therapists for hip pain. There's always a funny story associated with it. And yes, some have actually had knee arthroscopies to look for the source of their knee pain. So the physical findings, like we mentioned before in that first slide, is the classic is kind of a limp with an externally rotated foot. And the reason external rotation keeps coming up over and over again is because it's the way that the slip occurs, right? So the slip occurs kind of posteromedial. So they naturally turn their leg out because that's what feels comfortable. And that's what actually seats the epiphysis in the acetabulum. So our classic finding with that obese adolescent with externally rotated gait, hip pain, and then when you try to do an exam on the table, they have zero internal rotation. You actually can't even internally rotate their hip, or they have pain with attempted internal rotation. So that's one that you probably even know before you get the X-ray that it's a skiffy. Now, it's important to remember too that there's two different types. So there's what we call a stable skiffy and an unstable skiffy. So a stable skiffy, I guess I'll go to this slide first. So different words we kind of throw around, right? Or acute and chronic, stable and unstable. So acute and chronic is just basically whether their onset of symptoms, meaning the limp or pain, is less than 3 weeks or greater than 3 weeks. And then for stable and unstable, it's whether or not they can bear weight. So somebody who comes in and has 2 months of a limp and hip or thigh pain, and they walk into the office, to be seen, that would be a chronic stable slip. The pediatric orthopedic emergency is really more the unstable slip. So these are kids who show up past that stage, and it probably is a progression. They probably start out as a stable slip, and then it goes on long enough that it actually becomes unstable. So these are kind of examples of stable or chronic stable slips. So the frog lateral usually shows it a little bit better. And this is a good example on the right here because you have one hip that's normal and then one hip that's abnormal. So you can see on the normal hip how the epiphysis matches the metaphysis perfectly. Whereas on the other side, the physis looks a little bit more open, right? The other one's starting to close already. And you can see, right, that the epiphysis is kind of sliding off posteriorly here, or the metaphysis is going north. Now, I know that this one's been going on a while because I can see that the femoral neck's already been remodeling. So you can see it's already smoothing off, right, the top portion of the femoral neck. And you can see they're creating all this new callus down here. It's almost like they're trying to heal it. And they're like hanging on, right? It's like hanging on to the epiphysis, trying not to let it continue to slip. So it's definitely been going on for at least a few months. Unfortunately, sometimes they walk in, and it's like the X-ray on the right, where it truly acts almost like a femoral neck fracture, right? So these are kids that don't usually walk into the office. A lot of times, most of the time, they go to the ER because they have acute pain. Their leg is externally rotated. They're lying, on the ground, can't get up, and are taken to the emergency room. Now, anytime we see any slip, we take it seriously because there are also, and we've actually had patients in our practice show up with a stable slip, and then they're referred to the ER directly. So do not pass go, do not collect $200, go right to the emergency room, and they end up slipping on their crutches on the way out the door, or on the curb outside, or on the way into the ER. And we have an X-ray, in the office that looks like a stable slip. And then sure enough, by the time they get to the ER, they have an X-ray where the epiphysis actually completely fell off. So these are kids that we treat them all as an urgency, even when they're stable. So those kids will send right to the ER and we'll treat within 24 hours. But if somebody shows up already with an unstable slip, they're unable to bear weight, those are kids we put in the same category that we try to actually treat it within 6 to 8 hours. So we'll book those kids for the same night and take them to the OR. Whereas with a stable slip, we'll book them for the next morning or the next day, as long as they're on complete bed rest and can't get up, out of bed until the next day. And the treatment is very similar for the two. So for a stable slip, we're putting an in situ screw, right? So a screw under fluoroscopy right up through the femoral neck and into the central third, right, of the epiphysis to keep it from slipping. And then for the unstable slip, there's two, right, different options. One is a gentle positioning. So very similar to a fracture table for a femoral neck fracture, is you can gently position their hip under live fluoroscopy with gentle internal rotation until the slip gets back to a kind of chronic slip angle, and then put 2 screws instead of 1. The reason we do 2 screws is because you get a little bit more rotational control. If you just put 1 screw in, right, you have 1 center of rotation so that epiphysis can kind of spin. So we put 2 screws in just to hold the epiphysis on. Or you can actually open the hip and you can actually reduce, right, the head back onto the femoral neck. which is obviously a little bit more invasive and a little higher risk of avascular necrosis of the head, dying later on. In general, unstable slips have a much higher risk of that same outcome as that septic hip, that avascular necrosis. It's about 20 to 25%. So even of all kids walking in the door with an unstable slip, that risk is 20 to 25%. So we try to get them to the OR quick, just to stabilize it. All right. So how about that one? How about Skippy? Anybody heard of a Skippy?
I have a question. Is there any like gender differences in this one?
So it's a little more common in males. Yep. So it is a little bit more common. I don't remember exact numbers, but it's not 1-to-1. Yeah, male to female. And this is something that Dr. McPartland has a strong interest in. So even the ones that we treat, for a stable, most show up in the kind of stable, period, and we take them to the OR and we do an in situ screw fixation, say like this. But you may notice, right, that we didn't fix their initial slip problem, right? We just kept it from slipping further. So they're going to have, right, or they're going to have an abnormal head-neck junction. So a lot of these kids actually develop impingement. And actually will kind of hit into the acetabulum and develop arthrosis a little bit earlier. So one of Dr. McPartland's specialties is actually looking at these kids post pinning to see if there's something we can do while they're still young and healthy to prevent that from happening and having them get arthritis when they're in their 30s, 30s and 40s. So a lot of those are a long-term problem. All right, let's see what we can make it through. They actually do get a little shorter as we go through. So 3, compartment syndrome. I bet a fair number of you have heard of compartment syndrome. So this isn't one that's just for pediatric, right? So this is for all comers, but it certainly happens in kids, right? So compartment syndrome is this injury-induced increased pressure in a closed space. So all of our upper and lower extremities, right, are divided into compartments. So the swelling happens inside the compartment, and the tight fascia keeps the swelling from being able to go anywhere. So it just starts to compress inside the compartment, and then it can start to compress blood vessels, right, and nerves. In kids, the most common is a tibia fracture, and most commonly center of the tibia up, so kind of proximal tibia, which makes sense, right, because the distal tibia is actually just a lot of bone, tendons, and skin. Right, there's actually not much muscle mass, right, in the lower half of our tibias. So most of our compartments, so our muscular compartments, are in the top, right, the top half of our lower extremity. So it's not always related to fractures too, right? So we think of fractures a lot, but it can happen because of infections that are untreated or undertreated. Simple things, right, like IV infiltrations that unfortunately happens a fair amount in upper extremities. In both kids and adults. So extravasated IV that isn't removed and continues to extravasate. And then blunt trauma. So no underlying fracture, but a history of a blunt kind of injury. These are the classic 5 Ps, right, to look out for. So pain, pallor, paresthesias, paralysis, and pulselessness are kind of like the top 5. They did some more recent studies for pediatric over adult, and we actually found that probably more with the kids, it was kind of an increasing need for pain medication. Was probably the most sensitive. So if you hear from the nurses that they're requiring more and more pain medication in the last, say, 3 hours, like they took in the last 3 hours or what they took in the previous 24 hours, that's always kind of a red flag that they might be developing compartment syndrome. And this is one where you just have to go evaluate the patient. It's a clinical, diagnosis. There are ways to help you out, right, with monitoring. So we have an A line you can use. So true A line, just like out of the ICU or in the OR, is a great way to do it. But they also make these striker monitors, which are nice because they're compact. Come in a little case. The residents have one in the call room where you can actually bring it to a patient's bedside. And you inject just a little bit of normal saline into the compartment, and then it measures the compartment pressure. There's a couple different cutoffs people use for, what is compartment syndrome based on this. There's an absolute value. Some people would say any absolute value of greater than 45 in a compartment is compartment syndrome. Some people use a number within the diastolic blood pressure. In other words, they take their blood pressure, they see what the diastolic number is, and say their diastolic is 70, and then they measure their compartment. And if their compartment pressure is within 20 of their diastolic blood pressure, they would consider it compartment syndrome. But if you really talk to any of the trauma surgeons, anybody who does kind of trauma orthopedics, it's still a clinical diagnosis. You can tell from their clinical picture if they have compartment syndrome, their level of pain. Where this comes in handy is for the folks who are intubated and sedated. So you can't get a good clinical exam because they're really not giving you any feedback. Then a compartment monitor can actually be helpful. For pediatrics, one of the classic ones we always test the residents on is proximal tibia fractures. So like the one on the right up here at top is a tibial tubercle fracture. And this is kind of a proximal tibia, almost kind of like a buccal fracture at the top of the tibia. It happens here in the anterior tibia because this is the very start of the anterior compartment. And there's a little branch, the anterior recurrent branch of the anterior tibial artery that comes right around here. And it can get kind of severed when they fracture here, and then it just bleeds down into the anterior compartment. So it just keeps filling and filling and filling and filling the anterior compartment, and these kids can develop compartment syndrome. So the treatment is surgical, right? And it's right away. So use the same idea. We try to get these to the OR, within hours, basically as soon as they're diagnosed. So a lot of people will say time is tissue, right? So every minute counts for compartment syndrome. So for the lower extremity, just as an example, right? I'm sure in anatomy, everybody remembers this, right? So 4 compartments of the lower leg, right? So you have the anterior and the lateral, so 3 and 4. And then you have the posterior compartment, right? You have the superficial and deep. So you have to release all 4 compartments. So depending on where you are in the body, right, you have to release all of them. So with different incisions and ways to open those compartments. In the lower leg, you can usually do it through 2 incisions. You can usually open the anterior and lateral through 1 incision. And then you can open both the deep and the superficial through a single incision on the medial side. And then the same idea of going back to the OR at 48 to 72 hour intervals to assess tissue. And if any tissue is dead, to debride it to prevent infection. And then just keep going back to the OR, as many times as you need to before you close it. And these are a lot of times, these are folks who need special coverage afterwards, because once you open up those compartments and they swell like that, it's very difficult to get the skin primarily closed. There's a very high chance that you're probably talking about some type of plastic surgery closure for people who have compartment syndrome. Most commonly, though, we base our incision where we base it so that there's no exposed bone. So if you base your incision directly over muscle, then all you have to do is skin graft. So you can do a split thickness skin graft over top of it. So we try to stay away from bone, because if you leave exposed bone, then you have to do some kind of flap coverage or some type of product like Integra, over top of it. All right, so the last 2, all right, we'll go through them really quick. So open fractures, right? So same thing, not necessarily just pediatric, but open fractures, right? We grade kind of 1, 2, 3. And some of you, I think, listed in on our fracture conference on Monday morning. So you hear them say, it's an open fracture, and they say grade 1 or type 1, 2, or 3, right? And then sometimes they say it's a 3A or a 3B or a 3C. So this is the breakdown. So 1 centimeter is kind of the classic breakdown for 1 versus 2. So less than a centimeter or greater than a centimeter. And then for grade 3, it's really an extensive open soft tissue injury. And then A, B, and C is whether it requires soft tissue coverage. And the worst of the worst, right, are the ones that are open and then have an arterial injury requiring repair. A lot of these in kids are kind of these tiny little poke hole type 1. Because kids are a little bit more flexible and malleable and can develop these, kind of mild openings, especially of upper extremities. But as you go up in those grades, right, the higher the risk of infection. So the most important kind of indicator that they found to prevent infection open fractures, believe it or not, number one wasn't their time to the OR. It was actually their time to antibiotics. So we try to get them IV antibiotics as quick as possible. And that'll sometimes come into play when they get transferred to Robert Wood from an outside hospital. So we like to know about it as soon as possible because we can make sure they gave out IV antibiotics before they left the other hospital, because the transfer time can be 3 to 4 hours, for these to come to our hospital. So we try to make sure that they get immediate IV antibiotics. And then same idea with afterwards. A lot of these require multiple debridements after the initial debridement. So sometimes we do temporary fracture stabilization, like external fixators, until we know that we're done washing it out. And then we plan with the last washout and surgery to do both the internal fixation, plates, screws, rods, things like that, and do the appropriate closure. So sometimes we'll have our plastic surgery folks come look at it while we do a couple of the INDs, so that they know on our third or fourth or final kind of IND and closure if it just needs a skin graft or if it needs a flap. So then you can do your final washout, internal fixation, flap, or skin graft all at the same time. So I'm going to hold off on, so elbow injuries I threw in there just because the supracondylars, we're not going to go over all elbow injuries, but the supracondylars can be particularly bad fractures because of their proximity to the brachial artery, right? And the radial and median nerves and the ulnar nerve that go right by the elbow. So these displaced supracondylars, a lot of these will actually try to take to the OR within 6 to 8 hours, especially if they have any change in their neuro exam. So if they have a change in their, say, radial, median, or ulnar nerve, say like a palsy, or if they have a pulseless extremity, even a pink pulseless extremity, so it still has flow, but you don't have a palpable pulse. Any change in the neurovascular exam, pretty much everyone's going to take them to the OR for a reduction right away, even if it's at 2 o'clock in the morning. So for the sake of time, and then for the sake of a little bit of discussion on anything, I'm going to stop with that one. So I think we have a mix. Right? We have a mix of 1s through 3s. You think? Are there 4s on here too?
It should just be M1s and M2s.
2s. Okay. Very good.
And then I think Peter will throw in the attendance form in the chat.
Yep. So
that's great. Thank you, Dr. Adolfsen.
You guys are just getting through the preclinical stuff and aching to get to some clinical, some clinical stuff.
So, Dr. Adolfsen, I actually had another question.
Yeah.
When you're dealing with these cases that need a flap, how often are you doing them, or do you normally refer to like a plastics person on the service?
Yeah, most of us nowadays, I think back in the day, most orthopedists were doing their own skin grafts. They probably drew the line at split thickness skin grafts. So, some orthopedic surgeons still do their own split thickness skin grafts, but vast majority have switched over now to having a plastic surgeon colleague do, especially full thickness or flap coverage. So plastic is almost always involved, and it's easy to get them involved because you're taking them back to the OR every 48 hours to 72 hours anyway. So you're just basically letting them know the next time you're going back, and they kind of peek their head in, look at it, and can plan ahead so that when you come back for your final washout. And I'd say nowadays most have even switched over to letting the plastic surgeons do the split thickness skin graft. It actually kind of works out well that way because you're less likely. So it's interesting. They did a study in the orthopedic oncology realm, and the orthopedic oncology places that were actually doing the best job of having the lowest number of local recurrence of tumors were the orthopedic oncology hospitals, where they actually separated into 2 teams. So there was a resection team, and then there is a kind of a plastic surgery / orthopedic reconstruction team. And there was different surgeons. So they didn't have anything to do with the other part. And what they found basically was that when one orthopedist was in charge of resecting the tumor and then also having to reconstruct it, they were probably more likely to leave a little bone or a little soft tissue because they say, oof, if I take all this away, it's going to be really hard to reconstruct. I'm leaving this huge gap. How am I going to fill this? How am I going to fill all this in? So they probably had a little higher likelihood of recurrence because they were leaving a little bit of extra tissue because they were also in charge of doing the reconstruction. But when it's somebody else's problem, like a plastic surgeon or somebody else, you're more likely to resect whatever you need to resect. You say, oh, whatever, it doesn't look good, has to go. It's not my problem. It's somebody else's problem. They have to come in and reconstruct it. So similar for kind of open fractures, infections, things like that. You want to eradicate the infection first because you're not doing anybody any good if you end up coming back to the OR over and over and over and over again because you didn't resect enough tissue. So I don't think any of us have a problem having the plastic surgery folks on board and then taking care of it at the final IND.
Makes sense.
Hi, Dr. Adolfsen. Thank you so much for this talk. I just had a brief question. Would you say, like, besides the age of the patients, obviously, would you say there are any differences between general orthopedic practice and pediatric orthopedic practices? And if so, what would those differences be?
Yeah, definitely. So in general, you mean, right? Just as a as a specialty. So going into like say general orthopedics versus peds ortho.
Exactly, like maybe adult orthopedics versus peds.
Yeah, absolutely. So great question. So very different specialty. So peds ortho, it's interesting because I really think too, and a lot of us have said it in the past, we almost feel like some of the subspecialties of ortho should almost kind of be, we almost wish that they were 4+2 or 3+3 instead of 5+1, right? So everything in ortho is a 5-year residency. So you do 5 years of general ortho, and then every orthopedic subspecialty is 1 year of fellowship. So if you go into peds, it's 1 year. Do joints, it's 1 year. Hand, it's 1 year. Tumor, it's 1 year. You know, everything is just 1 year after the 5. But peds in general, it's interesting. You know, they're definitely not just little adults. It's actually a completely different science. So the things that we treat, the bread and butter kind of peds ortho, is a completely different science. Take, for example, club feet and hip dysplasia and all of the neuromuscular disorders and syndromes and everything that we treat in peds ortho are a completely different basic science. The trauma, you know, there's definitely some overlap, but again, the treatment modalities are very different for peds versus adult because of their open growth plates, right? So you have physes at the ends of all your long bones. So we're not going to use a lot of intramedullary devices and things like that because we can't go through the through the physis. So so it's very very different, you know. And I didn't know, you know, when I went into ortho, I was kind of interested in peds first. I was definitely more interested in the pediatric population, and then I was more kind of mechanically oriented. My whole family are engineers, so I was the first not to go into engineering. So I kind of naturally kind of picked ortho just because it offered me the possibility of doing peds. And you know, the mechanical side at the same time. But it's funny, when I started my first and second year, I changed my mind right away. I decided, I was like, well, I kind of like hand, kind of like sports. I kind of went back and forth for 3 years and then came back to peds, you know, as a third or fourth year. But the way it's set up, you'll get a bunch of exposure to everything in your 5 years. So in your 5 years of ortho, you're going to do there's ACGME requirements to do a certain amount of time for everything. It's just, you know, when you look back and you say, you're like, man, I wish I had more than a year at my fellowship. I did like 50 extra total joints, which I'll never do again. And I wish I had that year to learn about some more crooked kids.
Thank you. That was super helpful. I appreciate it.
Yeah. I think going in, just keep an open mind because you don't know yet what and your rotations are designed that way. So most orthopedic residencies kind of have a team approach where you rotate through services twice. So in other words, you'll kind of do a service as a junior resident, and then you'll rotate through the service again as a senior resident. So that, like, you know, at Yale, the trauma service was a 5, a 3, and a 1. And the joint service was a 5, a 3, and a 1. And peds was a 4 and a 2. And hand and sports were a 4 and a 2. So, you know, you were a team together as a junior resident, a senior resident. The first time around, you were a little green, and then the second time around, you were the chief. on the service. So you'll get a ton of experience in the 5 years. I kind of like that about ortho. I feel like ortho is probably the most efficient of the surgical residencies. I feel like some of the other residencies like surgery residency, and I mean, you do a ton of residency, or neurosurgery, we do 7 years, and I feel like ortho, you get a lot done in the 5 years, and then you only have to do 1 extra year if you're going to go into a fellowship. And I guess most people do, right? Over 90% decide to do a fellowship at the end of their 5 years. And I definitely encourage everybody to reach out. I think it's great with Dr. Cott. I'm sure